Hello everyone. Today a 58 years old male with a history of chronic smoking from 15 years admitted at our hospital with left-sided chest pain and a shortness of breath from 8 hours, and he had a history of the left-sided chest pain from 2 days. So we after admission we had checked the BP. He was hypertension. There was that BP was 200 by 100. So hypertension, anti-hypertensive management was also there, and saturation was checked. Saturation was normal, but in auscultation finding there was some crepes in bilateral lungs. And when we had done an X-ray, there was some chest X-ray. There was some features of heart failure, and in ECG you can see that there is some special things. You can see that the axis is normal, but you can see look at the AVR lead, there is the ST elevation in AVR lead, and as well as there is the ST depression in V1 and V2. And you would know that normally there is the S greater than R in V1 and V2. So, and V1 and V2 becomes negative QRS complex, and gradually it becomes positive up to the V5 V6. Here you can see that here is the R greater than S in V1 and V2. So it's a case of posterior wall AMI, and posterior wall is supplied by right coronary artery, and if the right coronary artery is blocked, so it is a posterior wall AMI. We had seen that there is the ST elevation, so it is a case of STEMI in posterior wall AMI. So now we need to do the posterior. We had done the top T was positive, so it's a case of proof that it is a case of AMI. And after that we had done the we need to take the posterior wall leads, that is the V7 and V8. So if we see that ST is elevated in V7 and V8, it is STEMI. And if we see that there is a depression in V7 and V8, that is the NSTEMI. And it is also the reciprocal changes in V1 and V2 ST depression. So it's a case of the posterior wall AMI, and the heart failure occurred due to posterior wall AMI. Okay, thank you.